Hello and welcome to the March 22 review of the recent literature in lupus. I'm Ed Vital, I'm the chair of the Lupus Forum and I work in the University of Leeds, and I'm very pleased to be joined today by my good friend and colleague Laurent Arnaud, who is a professor of medicine at Strasbourg University. And we're going to be going through some of the highlights of the literature from March 22. We'll be showing you some of these papers and you can look on the forum to download some more detailed slide sets. So, good morning, Laurent.
Bonjour, Ed. Bonjour, everybody. Really happy to be here.
So shall we start by looking at a few papers that all relate to recommendations, guidelines, and scoring systems. So I'll just take you through those first of all. So first one we selected was one that was a EULAR recommendations article, and this is about cardiovascular risk management. So there have been a few EULAR recommendations on cardiovascular risk. Initially, they did a recommendation for management in rheumatoid arthritis, psoriatic, ankylosing spondylitis, which has been updated. And this one aims to cover some other diseases, including gout, vasculitis, many of the connective tissue diseases, in particular lupus and antiphospholipid, where you might have particular problems with the cardiovascular risk related to inflammation. And specific features of the disease. So these studies tend to work as forming a task group of experts, defining some questions or PICOs of interest, and performing a systematic literature review and forming some consensus on the recommendations. And I think this is well worth reading. There's too much detail to cover here, but there are overarching principles that guide everything about awareness of cardiovascular risk, screening, management, and information to patients. And then if you go in to look at the specific recommendations, there are quite a few detailed points concerning specific diseases, so particular aspects of the data related to certain diseases, such as steroids in giant cell arteritis, or the use of aspirin in patients with lupus or antiphospholipid. So it's a very useful resource.
I think it's actually very interesting because we know that the cardiovascular risk is strongly increased in lupus patients. And we need to define a bit better our strategies, such as the targets for the various cardiovascular risk factors. And I think this is the first time that it is very clearly said that, for instance, the target blood pressure in systemic lupus should be 130/80. And that's really a good advancement, I think.
Yeah, I agree. And I think we're going to come back to this subject a bit later. But as we get better and better at treating disease activity in lupus, the main things we need to do to improve mortality and longer term outcomes actually relate to these related issues like cardiovascular risk as well.
So this is indeed great that we have clear recommendations. They have just been published. So I think many of our either readers or people going to Lupus Forum have not heard about it yet. So this is much expected update in a way.
Yeah, and it also helps to highlight where there are gaps in data that need to be addressed by future research.
It's perfect, actually.
Okay, so the next one we have this is actually a paper where I was an author. So this is from the BILAG group, which I chair. So there's a lot of talk about disease activity instruments in lupus, and I think I would broadly summarize this as we have two instruments that are mainly used: the SLEDAI and the BILAG, and everyone agrees that the SLEDAI is faster and easier, and therefore most people prefer to do this tool. But that comes at a cost, that it doesn't capture all the features of lupus, it doesn't have the ability to measure change, we can't summarize different organs, like, for example, to say the skin got better and the joints got worse. And there are some features that aren't covered at all, like hemolytic anemia. So this project was the BILAG group. We felt that we could improve things by making the BILAG easier to use. So what happens here is it's just, again, if you look in the paper, you'll see how we developed it. But essentially, it was to try to make the BILAG into a one-page assessment that can be done quickly and with fewer errors. So we went through prototypes, developed different versions, rated the items. So you see the common items. The rare items are just on the back page. You don't have to do them most of the time. And 90% of patients, you just have to do a single page assessment. And you can work out the score straight away. So we developed these prototypes, and then we did an exercise where we got some rheumatologists, some of whom were specialists who were familiar with using these tools, and some of whom were less familiar, maybe hadn't had much training with them before, working in non-specialist centres. And we asked them to go through a case book of 10 cases where they had to read a complex lupus case and score the BILAG. And they were given either the standard instruments or this new tool. And what we found was that the accuracy was much better using the new tool, and the assessments were performed faster. So in fact, actually, the less experienced rheumatologists in the general centres were performing with the same accuracy and speed as the experienced BILAG users. And so this is now the recommended tool to be used whenever you need to do a BILAG 2004. You still get the same data, it's just an easier way to do it. And we use this in my clinic now. And actually on the Lupus forum, there's a video talking through it in a little bit more detail, explaining how to use it, and a link to where you can download it.
Actually, I've had the opportunity to try it a few times, and it's true that you perform much faster. Actually, I think the items have been arranged in a very clever way, and so you really gain some speed. So that's really great, because that's the main comment that is often said regarding the BILAG, is its complexity and the time it takes to fill in the papers. So that's a great achievement, I think.
Yeah, and I think the other thing I thought, I mean, maybe it wasn't exactly what we set out at the beginning, but we started to do the project, what I thought is, how do these things really fit into routine care? Because people accept, okay, if I want to prescribe a biologic, maybe I have to do a SLEDAI or a BILAG, and maybe I have to, or maybe if I'm doing a clinical trial, but do they, I don't know what you feel. Do you think that physicians should be doing some sort of assessment regularly whenever they see patients, or should they just act on their clinical instincts?
Yeah, that's a really complicated question. I think that for now, we don't really have guidelines that actually guide it through the detailed assessment of disease activity, such as when the patient has this or this in terms of disease activity, you do this or this. So I'm not actually sure that this is much needed outside of trials.
I think
there's also the question of the validity at the individual patient level. Some instruments have been derived to capture mean or median disease activity for a population, but then for a given patient, what is going to happen when you perform it regularly? How are you going to infer the changes in treatment based on that? That I think are great questions.
Yes, exactly. If you perform your clinical assessment, would you change your decision as a result of a score? I'm not sure, but of course we saw in rheumatoid arthritis how the DAS28 did start to infiltrate practice outside of trials. I mean, I think the main things I thought were, one is that we're increasingly, this is UK practice, we're increasingly having to communicate between each other. So if a general centre wants to prescribe a biologic for lupus, they usually have to submit the case to a multidisciplinary meeting at a specialist centre where we review and approve it. So you need accurate scoring unless you want to send the patient to another hospital. And I think the other thing I thought was, the other advantage is if you want to evidence in your notes, I did a good assessment, to show that you didn't miss something. This may help in that way.
Yeah, I agree fully with this, actually.
Okay. And then the next paper we have is evaluating the construct of damage. So actually, Laurent, you were an author on this one, so you can probably tell me more about it.
Yeah, sure, my pleasure, actually. This paper has been actually led by Ian Bruce within the SLIC group, as well as Sindhu Johnson. And the idea was very much to update the construct or the concept of damage in systemic lupus. We've been just discussing about the way or the best ways to capture disease activity, and it's the same for the damage. We have this SLIC damage index that will be used for quite a long time. And as often, I think the paradigm of the care of the patient has evolved, and so there are new ideas about what could be an updated definition of damage in the context of SLE. And this is very much what this is about. This is a very large study involving many people who've been discussing about what is the concept of damage. And I have been privileged to take part in this discussion. And I can give you a very simple example. We know that disease activity should be reversible and damage should not be reversible by definition. But we have some examples. If you take glucocorticosteroid-induced cataract, you can always change the lens in a way, and so it's reversible. Or if you take proteinuria that remains after the treatment of lupus nephritis, well, it can improve with drugs or sometimes. And so in a way, we felt it was important to update a few things. And this include two, I think, prioritized aspects. One is that we are now taking into account any damage as soon as it can be attributed to the diagnosis of lupus. And this can be before that the diagnosis is made. And this is a big change because in the SDI, you only count damage starting from the diagnosis. And the other thing that we felt was a great improvement is the fact that in some cases, with treatments or with functional rehabilitation, some kind of damage can improve in a way. So these are the two main changes compared to the previous version.
Yeah, I certainly, that first point I noticed too, that patients with lupus, they often have their most severe disease at the start. I often diagnose lupus when they're already an inpatient, maybe on the intensive care unit, and they already had damage to their kidneys or something. And so, yeah, I think that was a really important point. The other thing I noticed reading this paper, which I think I really agreed with, was that the existing SDI, you get, 1 point is quite severe damage. And some patients, and often patients will have 0, 1, 2 points only, which means it doesn't have much of a range to assess change.
Correct.
And in trials, you see it's sometimes hard to understand, this difference of 0.5 in SDI between one group or another, or 1 between groups, is how meaningful is that? And I think that's one thing that's set out to be addressed here, isn't it?
Absolutely correct. We are expecting a weighting that would be more representative of what was to be expected in the context of lupus in a way.
Yeah, and so maybe that will also make it a bit more close to what's meaningful to patients, perhaps, as well.
Yeah, I agree fully, actually.
So the process here, this part is not the whole story. This is just defining the framework of what's going to be.
Yes, that's just the beginning. It's really designed to be a long-term study to really update this concept. So this is just the first part, which is to study the construct of damage from a psychometric point of view. And then we are going to move on to what you described, which is the weighting of vignettes and things like that.
Yeah. Okay, so these are our paper. This is this first group of papers. Shall we move on to the next ones?
Sure, absolutely. So I think we have a nice section about interferon alpha. And the first one is a paper about interferon gene signature and the treatment with anifrolumab, which has been just approved by the EMA, actually. And the first paper, and you are very much a specialist of this, is actually about the interest of the interferon gene signature as a biomarker in the context of autoimmune diseases. We know there's an interferon signature in systemic lupus, but this is also true in other diseases. I'm thinking occasionally rheumatoid arthritis, but also dermatomyositis. So what do you think? Do you think that it can be used as a biomarker for diagnosis, for instance? Are you expecting some kind of reshape, like biological redefinition of the diseases?
Yeah, I mean, they're all good questions. I think mostly they're still questions. I've also been doing a project, another EULAR task force like the one we talked about at the beginning, to look at this subject. And the literature it's quite complex, and there's still work to be done. So there is a huge body of literature suggesting that interferon assays in general, of which the interferon signature is the one with the most evidence, can predict various different outcomes in lupus. So more severe disease, certain organ involvement, initial development of the disease. And this is across multiple autoimmune diseases. But I think we have to there are a lot of questions remaining. There are some sort of technical questions about the assays and which is the best and how exactly it should be performed. And then there are questions about what do we really want this biomarker to do? It's quite easy to find correlations between clinical variables and certain immune biomarkers, but you need really high quality studies to tell you what you want to do. And I think, like you say, diagnosis probably is one of those most prominent questions, that initial diagnosis of lupus can be quite difficult. Patients can have symptoms for a long time. ANA is not a very good diagnostic test. Primary care physicians find it very difficult. And if there was anything there that could get you firstly, diagnose people who get lupus earlier, but also just rule it out earlier, would be extremely useful to all the other ANA positive people. And then, as you say, the other intriguing possibility, and I think this again comes up in some of the other papers we're going to discuss today, is that there are many drugs that work better in interferon high patients, particularly anifrolumab. And if you have an interferon high group of lupus patients and an interferon high group of Sjögren's patients and an interferon high group of myositis patients, perhaps it may be logical to start thinking that if you're going to block interferon, we may not want to classify them under the original diseases anymore. And we might want to develop basket indications. So essentially I agreed with what the authors said here, that this is a biomarker with a lot of potential, but I do think there's quite a bit of work to be done before it could be used in practice.
And what do you think about its ability to predict flares in systemic lupus? Because there's a bit of controversial literature here.
Yeah. So the study designs, a study to predict flare. It's not an easy study to perform. You have to correct for a lot of covariates that may predict flare. You have to decide how are the patients being treated? What's the end point? So this is probably why patients report different results. But I think ultimately, for me, the idea of a biomarker that can tell me when someone's going to flare is you really have to be clear about what treatment decision will I make on a different result. So if I have a patient with well-controlled disease on azathioprine who's on 5 milligrams of prednisolone, can I say that it's safe to taper the prednisolone with this biomarker result and I should not do it with that biomarker result? Or to tell patients when they can stop their maintenance therapy that they had for lupus nephritis 3 years ago? And it's quite a high bar that needs to be met for evidence to really justify these decisions, I thought.
Yeah, I think it brings us to correct clinical perspective, because the measurement using ultrasensitive techniques of interferon directly in the blood is more and more available in many centers.
Yeah.
And so maybe we are going to inform or guide our clinical practice based on that for treatment change and so on. It's great options to come, I think.
Yeah. I mean, you have to ask these questions. Sometimes I ask these questions when I think about the interferon literature and I see what the validation we need to tell us whether to use interferon levels to make treatment decisions. Sometimes it makes me think, well, what about the things we already use, like double-stranded DNA levels and complement levels? Do they have this validation as well? And actually, the questions get broader and broader.
Mm-hmm. I agree. I think in the context of dsDNA, it's mostly pharos-A that has been validated, and we know that it's now not so used as before because it's radioimmunological technique. So I think this brings us very much to the next paper, actually, which is really about the response organ by organ to anifrolumab, which is a great question, actually.
Yeah.
And I think you are one of the lead author on this paper, Ed.
Yeah, I was an author on this, and on a few of the papers from this study.
Yeah, so I think an important question is always the same, that when you study response to treatment in trials, you use a composite index. It can be BICLA, it can be SRI-4, but it gives you a kind of mean idea of how the treatment is working, or is it efficient or not efficient. But then there's another question, which is on which organ manifestation does it work? And this is really crucial because although systemic lupus is a very polymorphic disease, some patients may have predominant articular or cutaneous manifestations. So it's really great to check whether the treatment is actually working on all these manifestations, but separately. So maybe you can comment on this paper, Ed, I think.
I mean, I think, yeah. So as you say, I think this is an important analysis we want to see for any new drug. How does it work on different organs? Are there subgroups of patients who benefit more or less? And I think as we get these analyses and more drugs, we'll start to see some differences, and maybe we can make more informed choices about which of the therapies for which patient. So in anifrolumab, most of these non-renal studies, the majority of patients have either skin disease or musculoskeletal disease, with a lesser amount maybe of hematological and of course the immunological features of the disease. And I think one interesting aspect here was that one thing people have always noticed with the interferon pathway is that the efficacy in the skin seems really good. And that makes sense that the skin has an environment of very high interferon activity. And I see a lot of patients with bad skin disease who don't respond well to B-cell directed therapies that we used before. So this is very nice to see that we have another class of therapy that works well there. There was a little bit less certainty in some of the musculoskeletal data there was a bit of a difference between the phase 2 and the 2 phase 3 studies of anifrolumab on the effectiveness in the musculoskeletal system. And so one of the purposes of this was to pool the data together to get a bigger sample, and then and also to allow to look at other ways of measuring musculoskeletal disease, because the SLEDAI essentially says arthritis, yes or no, which may mean that some people who respond aren't captured because they didn't 100% respond. And BILAG has a little bit more grade between like severe, moderate, mild, but there's still a little bit of possibility that it may not be the most sensitive instrument. And on this one, that we have more analysis of the swollen and the tender, the joint counts, to back up the fact that anifrolumab did show efficacy in the musculoskeletal system, which is so I think that's probably the most important message from this paper.
That sounds actually great. I think we have another paper about the same theme. Which is actually dedicated to very important aspects, such as the PRO in the anifrolumab trial, actually. This is a post-hoc analysis of the phase 3 of TULIP-1 and TULIP-2, which are the 2 pivotal phase 3 studies for anifrolumab, actually, and it reports about PROs, such as the global assessment for the patients, the SF-36, the quality of life and fatigue scores, which are obviously very, very important aspects. And it's quite interesting to see that the BICLA responders report more significant and clinically meaningful improvements in some of these aspects, which are, of course, very important. There's the efficacy on disease activity, but there's also the efficacy on what impacts the patient on a daily basis, such as these PROs. So what are your views on that, Ed?
Yeah, I mean, I think partly this is important because of we have had several studies where the SRI-4 was chosen as the primary endpoint. And anifrolumab is the first licensed drug that uses the BICLA endpoint. And well, you can have a very long discussion about the difference between these different endpoints and which ones are the most meaningful. But we don't have time today for that. I have my own opinions. But I mean, I think the simple point is it's just when you have an endpoint that people may be less familiar with, it's more important for them to understand what does that mean to patients. And so I think this is very useful in that respect, that it helps us know that if a patient does achieve a BICLA response, the patient will feel better, and the patient will feel better and of course lupus quality of life I think is a very good tool because of the way, as you see in the table on the slide there, you break down all the different manifestations of lupus, which could be quite varied. So body image may be the most important feature to one patient, but pain may be an important feature to another patient. So it's useful that you can break down these different domains and see it like that, and that it seems quite convincing.
I think we have new outcomes such as remission or the LLDAS, which are more and more incorporated in the trials to come. But it's true that for these composite index, SRI-4 or BICLA, is actually important to know how it translates to the patient, because it does not appear very transparent at the beginning. So studies like this one proving that when you're a BICLA responder, you actually improve the quality of life are absolutely crucial.
Yeah, I think there's also an issue. The other, I mean, the whole area of the primary endpoints of these studies does need more work, and there is that work in progress. But if we can't articulate what that primary endpoint means, it makes it difficult for physicians to know, how good is this drug before I used it in real life, and for payers to know, how good is the cost effectiveness of this drug. So that's why.
Agreed. As you know, we have just concluded the PISCUS study, which is an international standardization of PGA in systemic lupus, to be published in a good journal. And it shows how a simple instrument is actually very complex. So I think these studies about how to interpret, how to rate, how to standardize the rating of these different composite index are super, super important.
Yeah. And ultimately, what you see, I still feel, despite the fact that I work on trials and outcome measures quite a lot, when I use the drug in my own hands and I see how the patient responds, it convinces me more than anything. I've had some very good responses with anifrolumab in my patients. So it's consistent with this.
We have another paper, I think. Oh, yeah, this is the phase 2 randomized trial of anifrolumab in patients with active lupus nephritis. This is a paper by David Jane as the lead author. And that's really interesting because we know that severe lupus nephritis are often excluded from the trials, and they are usually not included in the primary group of indications. And it's so interesting to have detailed data about whether the drug also performed in this disease manifestation. And it's true that in this context, actually, the phase 2 studied the proportion of response, complete renal response between the patients treated by anifrolumab versus placebo, but this was small sample size in a way. And there were very similar improvements, 69% and 70%, which of course is not a significant difference. So the primary endpoint was not met. So we are really curious to know more about the efficacy of anifrolumab in the context of lupus nephritis, actually, which is a big challenge for pharmaceutical companies.
Yeah, and again, it's interesting that so we have a few drugs with efficacy in lupus nephritis, don't we? We have belimumab, but there's a phase 2 for obinutuzumab, there's voclosporin, but it's just, again, this is a very different class, very different mechanism of action to those therapies. One interesting thing I noticed in this study, so although it's slightly disappointing that it's a negative study, as often the case, you see a few positive signals within it. And one interesting thing I noticed was that there was this intensified regimen with a higher dose of anifrolumab, and that hasn't been used in the previous studies. And the previous studies suggested that the standard regimen would really wipe out the interferon signature in everybody. So you would see little point in escalating higher than that. But I suppose what they're not really measuring, they're just measuring interferon signature in blood. And all cells produce interferon. And we know that in these inflamed organs, there's always local parenchymal or stromal cells that are capable of producing interferon. It can be quite enriched. So maybe that's an issue here. I think the other thing I wondered about when I saw this paper was that as we get more and more therapies and more classes of therapy for lupus nephritis, all of these trials are essentially treating a kind of a first episode of lupus nephritis where you try to induce remission, and then they will go on to some maintenance therapy after the trial. But we'll get more into more detailed questions again, won't we? What if they failed their first remission? What do you do then? Is switching class of therapy a good idea then, or first episode, second episode? Can we define groups of patients that will respond better to one drug or another? So that also made me think. I wonder if there is, despite this not meeting its primary endpoint, whether there is still a role for anifrolumab in the management of lupus nephritis.
Yeah, I agree. And this is obviously a very important question because, again, due to the highly polymorphic nature of the disease and the frequency of renal involvement. I think it's really important for pharmaceutical companies to demonstrate that their drug is working on skin manifestations on the joints, but also on the kidney, and that is absolutely crucial in a way for the future positioning of the drug.
Yeah. Okay, so this one here, we're sort of continuing this theme of lupus nephritis and the point we were just talking about, that who is it effective for? So we already have a trial of belimumab in lupus nephritis showing efficacy. So when, as compared, so, and I've started to think this is very important. We've regarded through the EULAR guidelines the standard of care as being mycophenolate plus prednisolone for most patients with most types of lupus nephritis. But the response rates you see on that can be only 50, 60%, something like that, which is not really what the kind of level we need. Now we've seen trials that indicate that addition of belimumab or voclosporin, or phase 2, we have obinutuzumab as well, will improve that rate. And it starts to make me think, well, is the days when mycophenolate and prednisolone alone was an acceptable standard of care for lupus nephritis, are things changing? Is this going to be regarded as history? Or does that depend on which patient and how severe your lupus nephritis is, whether you need that or not? And then if you do have all these therapies available to us, we have belimumab, we have calcineurin inhibitors, we could B-cell-deplete. How do I choose which I'm going to use if I want to use a combination? And that's the question that they addressed here. So the authors here reanalyzed the data from the study of belimumab and lupus nephritis, but they looked at different endpoints. So they looked at response endpoints like the primary efficacy endpoint and complete renal remission endpoint, but then also importantly there were some longer term endpoints that related to things like flares after an initial response or loss of renal function over the long term. And these are probably things that are much more important. Proteinuria reduction itself is a surrogate endpoint, I think, for the things that we really care about. So there are a few messages in there, and one of the most striking, which is on the slide there, was that the benefit of belimumab compared to placebo seemed to be greater for those two endpoints, the response endpoints, for patients who had with proliferative class 3 or class 4 lupus nephritis as compared to those who had class 5. And class 5 patients being those who generally present with a more nephrotic picture and perhaps less early loss of renal function. So that may help guide which patients get one drug or another. Particularly, I mean, there's been a feeling in the literature that calcineurin inhibitors may actually be preferable in patients who have class 5 or heavily proteinuric lupus nephritis, because they have a direct effect on podocytes. So perhaps I'm getting a feeling that we may start to have something to help us guide one therapy versus the other.
I agree, actually, and these are much needed questions. Actually, we have several drugs on the market with relatively similar positioning, so in a way it's really important for us to understand which drug should be preferable in which context, and this pertains also to the complexity of lupus nephritis with the classes. There's also the question of the ethnic background, which is also very important. Yeah. So these are great contemporary questions, and I think these studies, bit by bit, but they help answering these questions.
And do you, in your own practice, do you now use combination therapies, as in mycophenolate plus other agents, or first line, or do you just add these other agents if you think things? So
I have a Twitter account, Lupus Reference, and I've actually asked patients and doctors whether they were either using these combinations or treated by these combinations, and actually only a minority of doctors or patients are using this combination, less than 20%. And also what emerged is very much connecting to this discussion that most doctors had no very clear idea about in which context to use either belimumab or voclosporin in the context of lupus nephritis. So I think these are very much questions that are still very contemporary in a way.
And I think we probably need to update our guidelines to give people some framework to make these choices.
I agree, actually. I think we have one paper left.
One paper left, yeah. Do you want to tell us about that one?
I think it's about iberdomide. These are the results of the phase 2 trial of iberdomide in the context of systemic lupus. We know that this is a cereblon modulator. So this is a kind of new pathway that can be targeted in the context of systemic lupus, where there are many, many potential targets, actually. And in its study, which was a phase 2 randomized placebo-controlled trial, actually, the patients received either iberdomide, different dosages versus placebo, and the primary endpoint was the SRI-4 response at week 24. And a group of patients, those who received iberdomide 0.45 milligram QD, performed better in terms of SRI-4 response than the patients receiving placebo. So I think this is a nice signal for the beginning of the development of this drug. This is a phase 2 trial. We are expecting, of course, more to come.
Yeah, the thing that really struck me with this one was that that the effect sizes looked quite large. That we sometimes see lupus trials that seem like relatively small difference.
19 points, almost 20 points.
Yeah, and then within that, they also had some patients who they stratified them by an interferon signature and also by this AOS signature. And they showed that you could have 27-point differences, 30-point differences. So we have to see how this translates when we see the phase 3 data, but that seems quite exciting.
I agree, actually. We've had some disappointments, of course, in the translation from phase 2 to phase 3, but I think the phase 2 results will be very much expected, actually.
Yeah. So I think we've finished the papers we had planned to discuss. That brings our discussion to a close. It's great to have these conversations, as always, and it always raises more thoughts in my mind about the literature that I've read. And to think about how that might affect our daily practice. So it's been great chatting to you, Laurent. Thank you for joining me. And
thank you very much. Merci beaucoup.
And we'll look out for some more of these podcasts coming up on the Lupus Forum that we'll be doing for monthly reviews of the literature, and also when we have highlights for example, the major conferences. So it's good to sign up to the mailing list, follow us on social media, and you can register at lupus-forum.com, or just search Lupus Forum all as one word on Twitter and LinkedIn, and you can find the relevant feeds to get notified when these things come out.
Have a great day. Bye-bye.
Thanks. Bye.